The central anatomy of fifth nerve is very complicated. The small motor nucleus lies in the mid position in the upper lateral pons opposite the nerve root. It receives bilateral supranuclear innervation from corticobulbar fibers, which leave the main pyramidal pathway at the level of nucleus. Direct connections with proprioceptive fiber in adjacent main sensory nucleus allow a simple stretch reflex for mastication to operate. The jaw jerk test, the integrity of pathway, if greatly enhanced, indicate a bilateral upper motor neuron lesion above the mid pontile level, the highest stress reflex that can be elicited. The sensory nucleus is very extensive. The cell bodies of the sensory fibers lies in the Gasserian ganglion overlying the petrous apex. At least 50% of the fiber do not enter the main sensory nucleus but are concerned solely with stretch reflex activity. The other fibers from ascending and descending branches, the ascending fibers enter the mesencephalic nucleus of the fifth nerve. Their subsequent course and exact function is not understood, but this is the site of only unipolar neuron in the brain. The descending fibers conveyed pain and temperature sensation and synapses in the nucleus of descending tract of the fifth nerve, which lies adjacent to the descending tract itself and extend up to C2 cord level. The sensory fibers derived from the facial, glossopharyngeal, vagus nerve all join the same tract and relay in the same nucleus. The secondary ascending pathway fiber swing across the brainstem ventral to the central canal to become the secondary ascending tract of the fifth nerve, which is adjacent to the medial lemniscus. Adding sensation derived from the face to the arm and in the leg in lateral pathway. In the desiccation, their fiber are very vulnerable to damage by the midline, such as syringomyelia lesion, syringobulbar lesion, producing a classical sensory deficit, typically extending toward from the back to the head. This is also called onion peel or balaclava sensory deficit, which may leave sensation intact only over the nose and central face in the final stage of its development. So, main nucleus. So, nucleus of sensory nerve, fifth nerve are four nucleus: mesencephalic nucleus, principal sensory nucleus, and spinal nucleus are sensory nucleus, and fourth is motor nucleus of the fifth nerve. So these four nuclei having function of the fifth nerve, all like pain, temperature, sense of the face, are mainly supply of the faces from the this principal sensory nucleus. The trigeminal nerve is the largest cranial nerve and arises from the middle of the lateral side of the pons and passes forwards laterally across the subarachnoid space. It's having large ganglia which lies over the petrous bone at petrous apex. It's having three division: ophthalmic division, maxillary division, and mandibular division. Now talk about ophthalmic division. This is the first division of fifth nerve, lies below the sixth nerve in the lateral wall of cavernous sinus. It supplies the forehead, nose, and back up to the vertex. First division is lacrimal nerve, runs along the lateral rectus muscle to supply the lacrimal gland. It also supplies the skin over the lateral eyelid and brow. It picks up secretomotor fiber from the zygomaticotemporal nerve, which it's conveyed to lacrimal gland. In the skin, it receives proprioceptive filament from the facial nerve in this region. Second branch is frontal nerve, divided into two: supratrochlear and supraorbital nerve, which supply the skin of forehead and scalp of the vertex. They are prone to damage on minor injury in this area. The third is nasociliary nerve, has important autonomic and cutaneous function. The main trunk traverses the orbit, enters the anterior ethmoid foramen into the intracranial cavity, runs forward across the cubriform plate and exit into skull base, oscillate in the crista galli to enter the nose. It supplies the mucosa of nasal cavity, emerges at the lower end of the nasal bone to supply the skin over the tip of the nose, alar, and vestibule. In the orbit, the nasociliary nerve gives off branches to ciliary ganglia, two or three long ciliary nerves, which carry the pupillodilator sympathetic fiber and convey sensation from the cornea. This is the cardinal importance of the protection of the very delicate cornea. This sensation protects the cornea. The infratrochlear branches gives off just behind the anterior ethmoid foramen and lies on the medial wall of the orbit and supplies the skin of upper medial eyelid and upper side of the nose. Now, what is important here is corneal reflex. It is essential that otolaryngologists know how to elicit this reflex correctly. The afferent limb of the reflex is by the nasociliary nerve and efferent limb by the facial nerve. A pointed whisk of cotton wool should be used, and the examiner should ask the patient to look upward, then resting the hand on patient's cheek. The whisk should be applied to lower cornea, but taking care not to bring it into vision or blink reflex will result. The patient will flinch and eyeball will roll up and eye will attempt to close. Even if facial nerve is palsy, the eyeball will roll up and discomfort will be felt. The opposite eyelid will also close as this is consensual reflex. Absence of corneal reflex is often the first clinical evidence of fifth nerve damage and should be tested in all patients suspected injury of the fifth nerve and also in the patient of symptom having vertigo, deafness and facial pain. The second division of fifth nerve is the maxillary nerve. The middle branch of the fifth nerve lies in the extreme lower lateral wall of the cavernous sinus, exits by the foramen rotundum, passes through the pterygopalatine fossa, enters the floor of the orbit by the inferior orbital fissure. At first it lies in the groove in the orbital floor, then enter the short canal and exits on the face by the infraorbital foramen. It supplies the skin of the cheek, mid-lateral nose, lateral part of the alar, lower eyelid and mucous membrane of the cheek and upper lip. It's having following branches. The first is meningeal branches to the floor of the middle cranial fossa. Second is two branches of spinopalatine ganglia conveying the secretomotor fibers destined for lacrimal gland. Third are zygomatic nerve which lie in the floor of the orbit dividing into zygomaticotemporal nerve and zygomaticofacial nerve. After penetrating the zygomatic bone, carry the cutaneous sensation from prominence of the cheek. The three alveolar nerve convey sensation from the teeth, gums, adjacent palatine by the superior dental plexus. The anterior supply branch is the largest and supply not only the incisor and canine teeth but also the lateral nasal wall, nasal septum, lower eyelid and the skin of upper lip. These are the branches you can see in this picture. The pterygopalatine or spinopalatine ganglia. This is the very large ganglia which is suspended from maxillary division deep in the pterygopalatine fossa. It receives main contribution from the nerve of pterygoid canal. This carries preganglionic parasympathetic fiber derived from the pontine lacrimated nucleus by the nervus intermedius of the facial nerve and sympathetic element derived from the fiber of middle meningeal artery. Both groups of fiber are then relayed by the subsequent complex course of the lacrimal gland and lacrimal branch of the nasociliary nerve. The main outflow of ganglion by the orbital, palatine, nasal and pharyngeal nerve to the mucous membrane of the orbit and nasal passage which also supply the palate and upper gums and pharynx. The third division is mandibular nerve. This is the largest branch of the fifth nerve, include the motor branch. It exits from the skull base through the foramen ovale. The main sensory trunk being joined by the much smaller motor root in Meckel's cave just outside the skull. A meningeal branch re-enters the skulls with the middle meningeal artery through the foramen spinosum and conveys sensation from lateral middle anterocranial fossa. A small branch, the nerve to median pterygod, supply the median pterygod muscle, tensor tympani, and tensor belli palatini muscle. The main nerve then divided into anterior and posterior trunk. The anterior trunk convey the bulk of motor route to supply the masseter, temporalis, lateral pterygod muscle. The main branch of anterior trunk is the buccal nerve, which emerges from buccal branches of the facial nerve to convey sensation from the skin over the buccinator, mucous membrane of cheek, and posterior part of buccal surface of the gum. The posterior trunk is mainly sensory, divided into three main branches. First is auriculotemporal nerve, which passes beyond the temporomandibular joint to join the facial nerve, which distributed to supply the skin over the tragus, helix, auditory meatus, tympanic membrane, and superficial temporal branches of the skin over temporalis. It also conveys the secretomotor fiber to parotid gland, fiber derived from the tympanic branch of glossopharyngeal nerve by the otic ganglia. You can see the otic ganglia in the posterior trunk. The lingual nerve, which carries sensation from the presulcal trunk and floor of the mouth and lower gum. The temperature of the coffee is sensed by this branch, lingual nerve. It also carries the taste fiber of coda tympani from mucous membrane or anterior two-thirds of the tongue and conveys secretomotor fiber from submandibular ganglia of sublingual and anterior lingual glands. It communicates with the hypoglucous nerve. So temperature of the coffee is tested by trigeminal nerve, and the taste sensation of the coffee is sensed by the facial nerve or taste fiber of the facial nerve. And third branch is the inferior alveolar or dental nerve. Enter the mandibular canal running forward in the mandible to re-emerge on the chin at the mental foramen, dividing into incisive and mental branches, supplying sensory fiber of skin, mucous membrane of lower lip, jaw, incisor, and canine teeth. The motor component of posterior trunk leave the inferior alveolar nerve just below, entering the mandibular canal as mylohyoid nerve, supplying the mylohyoid and anterior belly of the digastric. Now, clinical aspect of the fifth cranial nerve. Damage to the trigeminal nerve is very important to the ENT surgeon. Involvement of motor root of the fifth nerve is quite rare. It seems to be remarkably resistant to pressure and distortion. So, motor root is less likely to damage. If damaged, the wasting of masseter is usually visible and easy to demonstrate by palpation. The patient clenches the teeth. The pterygoids are tested by the attempted jaw opening against the resistance and jaw deviate toward the paralyzed side. So, same side lesion, same side paralysis in the trigeminal nerve. Painless or painful loss of sensation over any part of face, particularly B2, is very sensitive. Repeated examination under the general anesthesia if necessary, biopsy of nasopharynx are vital in such cases to establish the diagnosis, and you can see the nasopharyngeal tumor in nasopharynx is the main cause of pain in this ophthalmic nerve, or you can say in B2 division of trigeminal nerve. The nasopharyngeal tumor most commonly arises in the fossa of Rosenmuller. Even though it's look like normal, you should do biopsy in suspected cases. And mandibular division is rarely involved, like oropharynx, tonsillar, and mandibular tumor. And it may have painful and painless lesion. Now talk about some. This is the trigeminal neuralgia picture in which Teflon piston is placed between the culprit artery and trigeminal nerve. Now, trigeminal neuralgia is the most painful condition in which it lead by aberrant artery. And pain usually distributed to the B2 and B3 region. So this trigeminal neuralgia is the most painful condition. It is mostly unilateral. The pain first having in lower canal region in the like tooth and lower jaw, then spread over the malar prominences. And you can see this is the culprit artery which having pressure of trigeminal nerve. Now talk about herpes zoster ophthalmicus. It is a most patient with this condition develop very severe pain and rashes over the area of distribution of ophthalmic nerve. The pain lasts between 4 and 5 days. During this time, the time of diagnosed rupture aneurysm, cranial arthritis, or acute frontal sinusitis may be seriously considered. The vesicle usually appear in like inner eyebrow on fifth or sixth day and may involve the entire distribution of nerve. Severe chemosis of eye, extraocular nerve palsy may further complicate the initial picture. And you can see in this case of the herpes zoster ophthalmicus in which rashes all over the distribution of ophthalmic division. Third condition is aneurysm dilatation of carotid artery. This is the other major condition elderly that can cause very severe pain in distribution of ophthalmic division with chemosis extraocular nerve palsy even may lead to blindness. This is usually very sudden onset, typically develop in elderly female with long lasting hypertension. So these are the clinical aspect and clinical importance of trigeminal nerve. Thank you so much.